Alright. So this was not on our PowerPoints, so I don't have a PowerPoint for this, but it was on our syllabus. So I don't know what happened with the PowerPoint people, but they didn't put this on our syllabus. So I'm just going to have to write everything. I didn't put it on our PowerPoint. I just have to write it for you. You'll just have to bear with me. Did y'all read a little bit? Did we get to this yesterday? Okay. Anytime you see neph, what does that mean? Kidneys. Think of that neph. So this is nephrotic syndrome. It's also called nephrosis. That's the neph. So you might see it called either or, okay, when you're doing your testing. This is where your kidneys are, the glomeruli, the little filters in there, are damaged, and the protein passes through the kidney into the urine, and it passes, from the blood, it passes into the urine, and then it's big drops of protein going through the kidney, so it causes protein in your urine. Okay, so you have, what is that called? Protein in your urine. Proteinuria. Start using your terms so you can just write them right off. You'll also have hyperlipidemia and edema. Have a lot of cholesterol because it's big and it's just passing through. The kidneys aren't filtering it, so it's just passing through. That's cholesterol. So you'll have a lot of that fat, the big molecules that we'll talk about in a minute when we go over the experiment. So they're passing through. So that's what nephrotic syndrome is. The glomeruli, not say it, are damaged, and the proteins are just passing through it into the urine. Okay. What happens when your protein in your blood, your serum protein level drops? Anybody know? If it doesn't stay in your blood, it shifts out into your interstitial fluids or your tissue, and you get that edema. Okay, that's what causes tissue edema. So if you have low protein in your bloodstream, you're going to see peripheral edema. Okay, so the signs and symptoms of this are going to be edema, weight loss, because they're poison. They're not getting all that stuff out, so they don't have an appetite, so they're not eating. Okay, so loss of appetite, weight loss, activity intolerance, and foamy urine. That looks familiar, huh? Let's talk about it. Why is it foamy? Why do you think? Protein in it. It's just got it all fuzzy. Looks like the tap on a beer. It's just real foamy and thick. Okay? They're not going to have as much urine output either. Why? And they asked a real good question, that the best question a nurse could ever ask is why? Because that's the only way you're going to find out something, and then you remember it because you understand it. Why would they have low urine output? We just talked about it. Protein has left the body, so all the fluid is where? It's out in the tissues instead of in their circulating system. So that's why they don't have as much urine. All that fluid is stuck in their skin and their tissue. Okay? So they're going to have, here's our signs and symptoms: edema, foamy urine, decreased urine output, loss of appetite, and weight loss. And all of these folks with any kind of kidney disorder, they're going to have activity intolerance. They're going to have less than 500 cc's a day of urine because it's all stuck in their tissue. Cc's are milliliters. Yeah, decreased urinary output. I haven't seen her this morning. She might be with level 1s. No, they're all hanging out. Right, so y'all got those? So what would we do with any kind of renal patient? What were our nursing daily weights. Strict down, no daily weights. We're gonna listen to their lung sounds, right? Because they're full of fluid. So remember our ABCs. We want to make sure the airway, breathing, and circulation, and then safety, or pain and safety, PS. So they got all this fluid in them. It's got to go somewhere. What if it's in their lungs and I'm not listening to their lung sounds? What's going to happen? Pulmonary edema, not good. You'll be in trouble. You'll be unemployed the next day if you don't listen to breath sounds. Respiratory effort, level of consciousness. All of these respiratory people, they've got that stuff in their body. They're not peeing it out. So all those toxins build up, and that's when you have that altered level of consciousness. They're confused because they've got all that toxin in them. Okay, so you're going to be checking for that every time you go in. Hi, how are you feeling? Tell me your name. You repeat. They're going to think you're crazy because you're asking them their name every 2 hours, 1 to 2 hours. But you're making sure that their level of consciousness is still where it needs to be. And then you're listening to their lungs to make sure that fluid has not shifted from their skin into their lungs. And listen to their heart rate. Because when we have too much fluid on board, does that overload our heart? Yes. Yes, it does. Okay. So we're going to do our daily weights, our I-Nos. We're going to listen to breath sounds, heart sounds. Check for edema. What did you say?
That increase the heart rate, or will it
It
just?
just makes it have a bounding sound. So you got too much fluid on board. And they'll be short of breath. Okay. Also, what's another telltale sign of too much fluid on board? Anybody that wants to do cardiac or has worked cardiac? What's a telltale sign? I don't even have to put my stethoscope on them. I can tell they got too much fluid when I look at them. The neck veins, they're huge. They look like water hoses because they've got too much fluid. Okay? So I'm going to check for distended neck veins. That's with any kind of cardiac patient, respiratory patient, or renal patient. Look for those neck veins, okay? If they're real big and they're wet, you need to be calling somebody.
If they big and wet, those veins?
Their lungs are wet and they've got
Oh, I thought you meant.
come on, Nate. It's Friday. Alright, some of the lab that they'll do, any kind of nephrotic patient, what are we going to do? Obvious, what? The lab's going to order a UA. And they might do the 24-hour urine on this one, because why? What do we got spilling in our urine on this one? Protein. So we need to know how much protein they're losing, right? So 24-hour urine test will be done on these type patients. And what kind of diet would you think they need? Low sodium. What else? Protein. They need protein because we're losing our protein. So it depends on what the levels are. They may adjust their protein intake. Okay. High protein diet, low sodium diet. Protein is meat, any kind of meat, fish, poultry, cheese, eggs. Think of your no carb diet. That's what that is. High protein. Okay. And they're going to give them steroids. Do y'all know why they would give them steroids? That's real odd. I mean, that's common. They give it, but the steroid helps keep them open. Yeah, and get rid of all that, some of that fluid. And what's another thing that we always give for fluid? People who have too much fluid. Diuretics. So we're going to give Lasix or furosemide. You got to get some of that fluid out of them. Okay. So everybody got nephrotic syndrome? Pretty much where you're pulling that protein that's coming out of the body because the kidneys aren't filtering it and it's going out. So then that drops your systemic fluid balance, changes everything. And they get fluid in the tissue, might back up into the lungs. And they have to give them steroids, diuretics, and maybe increase their protein in their diet. Okay? Let's see where else. High protein, low sodium. And you know what? I thought about something last night when I was going for you. Let's see. For pH. Yep. I thought of a good way to remember it. Any questions on nephrosis, nephrotic syndrome? remember, if you see F, that's kidneys, and just about all these nursing measures are going to be the same for any kind of kidney patient, because it's all about fluid with them, okay? Low sodium, high protein. So that's a good way. You won't have to remember everything over and over for each symptom. Each syndrome. They're all similar. I'm going to do something with y'all. If it sticks, okay. If not, okay too. If you already understand osmosis, diffusion, and filtration, yay. If you don't understand it, I'm going to try to help you. Okay, so because we're talking about dialysis, and this will make sense, that's why I'm going to do it now. When we start talking about dialysis, this is what it does. Your body has a built-in way of knowing what it needs, and it will try to correct itself, okay? So it uses diffusion, osmosis, and filtration to take care of itself. Sometimes it's worn out and it can't do it by itself, so that's where we all step in. Medicine. But this is a simple way of explaining this, okay? Diffusion is when, let's say, you're dehydrated or your blood's real thick. Remember how I talked about the concentrated orange juice? So let's say this is a drop of your blood. See how thick all those molecules are? That's got protein, sugar, salt, everything. That's a drop of your thick blood. It's very highly concentrated. Diffusion, the process of that is where, let's say this is your body, this is your blood. Diffusion is when it goes from a very high, thick, concentrated state to a diluted state, okay? To a less concentrated state. So that drop of blood, let's say it goes in the system and the system starts diffusing it. It says, oh, I know that that's too much, so I'm going to move some of that thick blood into this area where I have more water or a lower concentration of that so that it evens out. Does that make sense? So it went from a real high concentrated level into an area of less concentrated level. All right? And see how fast it's already diffused. It's already blended in. And now it's not concentrated, is it? It's even. So that's what the body will do. It says, oh, this is too much right here. I'm going to move it. And so it helps it move by diffusion into an area where there wasn't as much.
So diffusion is evenly dispersed.
It takes a high concentration to a low. It goes from a high to a low. All right? So now that highly concentrated drop of blood is now evened out. Okay? So then it has another way of helping itself. Osmosis. This is kind of the opposite. Okay? Diffusion happens with molecules. Like I said, sodium, potassium, chloride, protein, things like that. Osmosis is just fluid. So it has an area of low concentration, very dry paper towel, so dry area of your body. And this is super simplified, but it's the easiest way to know this, to make it make sense. So in osmosis, you're taking an area of the body that's got low concentration, and you're going to move that fluid to an area of high concentration. Okay, so this is my edema, let's say, and the body realizes, oh, I don't need that much fluid right there. So I'm making a wick. And so by osmosis, the process of osmosis, it takes this area down here that had too much fluid, and it's going to pull it to this less concentrated area, the dry area. And you can see it's already getting wet. It'll soak it up. It'll just wick it right up. That's osmosis. It is going from an area of low concentration and pulling and getting it back to high concentration. See, it's already wet up here. And if I let it sit, it'll just pull it right on up. That's osmosis. It's fluid only, though. Okay? Diffusion is molecules. Osmosis is just fluid. Low concentration is too high. Now, in a few minutes, by the process of osmosis, this won't be low anymore. It'll be high, right? Because it's going to be wet. Okay? Now, does everybody get that so far? Sometimes in the body, do y'all remember this way back from 8th grade science class or maybe level 1? There's a thing called a permeable membrane on your cell. Now each cell has that little, almost like a gel surrounding it. It's a membrane. It's what allows stuff to go in and out. If it likes it, it lets it come in. If it needs it, it lets it come in through that membrane. It doesn't want it, doesn't need it, it doesn't let it come in, right? But most things can pass through that membrane. So let's say this is my cell membrane. See, I'm already getting, see? So this is my cell membrane. It likes water, it likes sodium, potassium, chloride, everything I already put in there, and it'll let that float through easy, right? Just went right through that membrane, that cell membrane, permeable membrane. It just goes right through without any problem. But sometimes, like in nephrotic syndrome, or other things where your kidneys aren't working, that membrane is either worn out or it doesn't like it, it's gotten rigid and it won't allow things to pass through. Especially proteins, because sometimes they're not supposed to pass through our body. I mean, through our kidneys like that. We're not supposed to spill protein or anything, because protein molecules are thicker and bigger. So they don't go through that membrane as easy. They will just sit outside of the membrane, and the membrane says, it's too big, you're not coming through. I don't need you right now. But then sometimes the body says, there's too much in my blood, I need you to go. And it will use osmotic pressure, and it will push it by the force. Sometimes you have to give it force, and it will push it through. It'll push it through that membrane by osmotic pressure. The pressure outside that cell builds up, and it forces that protein or those large molecules to go through that cell membrane.
Okay, so what?
And it still passes through, and the membrane's intact, but I had to use pressure, right? Osmotic pressure. So that's filtration.
So
Having to use force to push it through a membrane. Does that make sense? Filtration. The other two kind of do what they want. They kind of can do it with water, it moves easy. The molecules are small enough they can go through. But when you have big molecules like proteins, they're not always going to go through. They're not supposed to when your body's healthy. So sometimes it pushes it through with osmotic pressure. Okay? So that is kind of the premise of what dialysis is, all right? So when we get into it, remember these, and we're fixing to go over it, and I'll refer back to that. Does that make sense to everybody? Yeah, osmotic pressure to push through the permeable membrane. So, we talked about glomerular nephritis this morning on our test. Got your hand out. Everybody got their hand out? Got our little guy ripping his hair out? It can be acute or chronic glomerular nephritis. I just need to stop saying it. What is it caused from? It's on our test this morning. Upper respiratory / strep throat. It settles after 2 or 3 weeks. It'll settle into the kidney, and it's one of those molecules that can't go through the filter, so it's stuck there. Okay? Okay, I've got some extras up here. You can come get one, or we can pass it back. Thank you. Just keep whoever needs one back there. Just keep it on. Okay, so Ms. Robertson.
So this diffusion, osmosis, and filtration, does that have to do with the nephrotic syndrome, or did you go take us into
No,
another thing?
it's going to be, just put it in parentheses, because when we start on dialysis, you'll need to understand it. It's kind of the process, the whole process of what the kidney does, just simplified, but it really comes in handy to understand that when we get to dialysis, because that's how dialysis works, either by osmosis, diffusion, or filtration. So, I just kind of want to show you now, because that way it'll start sinking in and it'll make more sense. Alright, so kidney's like, I can't get that out, it's too big. So it sits there and gets the glomeruli of your kidney infected. See? You can break that word down and you can tell what it is.
So it's caused by,
Upper respiratory infection or like strep throat.
But you did say you can have strep, come back 2 weeks later and then have that.
Yeah, it shows up 2 or 3 weeks later in the back because they're hurting in their kidney. Because it's traveled all through the body and then the kidney couldn't get it out. So now it's stuck in the kidney causing trouble, causing an infection there. Okay? They'll have headache, high blood pressure. Why do you think that is? Fluid buildup. Anytime you've got more fluid on board than you need, your blood pressure rises and you get a headache. Okay? They're going to have facial edema, around their eyes especially. And they're going to feel fatigued and tired, like we said with any of these kidney patients, because they're just not, their body is poisoning itself. It's not able to clean itself. Low grade temp. Instead of weight loss like the other ones that didn't want to eat, this one's got weight gain. Why is that? Holding on to fluid. Right. So they're going to be spilling protein and blood in their urine also, okay? Because that kidney is just irritated. So what would be some of the lab we would check on a person that came in like this?
burns,
Yep. We're going to do a UA. We're going to do a BUN, and creatinine, which remember yesterday we said the reason they check that on every kidney patient is why? Kidney function. If your kidneys are working like they're supposed to, the BUN and creatinine will be low. But if they're not working, like this one's not working because he's full of strep, your BUN and creatinine are going to be up. Okay? Because the body's not being able to filter them out and get them out. So they'll check for that. They'll also check potassium level. Because it's the same thing. The kidney's not trying to get it out. It could build up, and we know too much potassium does what to our heart? Slows it down, makes dysrhythmia and stuff. Alright? They might also do a strep titer just to see if that was the true cause. Okay? Alright, so we know, back to nursing measures, this is what NCLEX loves. What would you do for a patient with this problem?
dietary, protein restriction.
What are you going to do when you first get them, though?
Monitor iron.
Yep, don't do weight. We're going to check level of consciousness. Because remember, he's got a headache and high blood pressure. So I always want to check, start with the neuro first, because if the brain's not working, nothing else will. Check level of consciousness, especially if the BUN's high. Because that's going to confuse them. When all these toxins aren't getting cleared out of the body, they get confused. So we're going to check level of consciousness, put them on bed rest, watch their fluids, and weights. You know, vital signs and all that good stuff. That kind of goes along with weights. Vital signs should be, you should know about. It's just the end of hand. Okay? They're going to give them probably some antibiotics if they're running fever, because that strep throat never really got taken care of. So they're going to give them some antibiotics. They might, Horsley, you cannot catch a break, can you? All these women in here, leave. Diuretics. Because remember, he's got all that periorbital edema. He's got all that edema everywhere. We need to get rid of it, some of it, and his blood pressure's up. So they'll give him a diuretic to get rid of that fluid.
Will they go anti-hypertensive?
Yeah, they if it's bad enough, they will. This one's got low protein. Why do you think this one has a low protein diet? Going back to our filter that we just did.
Because it's driven over in there. Right?
Yeah, the kidney is not working. It's already struggling because it's full of strep throat. It's already got that strep germ in there. So, would we want to add those big, bulky protein molecules to it and say, here, work harder? No, we don't. So that's why you put them on a low protein diet. Because you don't want to overwork the kidney. You're already diuresing it, making it work faster, try to get rid of the fluid. You don't want to give it protein and push it through and force it. Okay? So that's why they have a low protein. This is like if they were acute. They come in, they're, it just happened. sometimes you can have this chronically, and this is kind of the precursor to renal failure. So if they have chronic glomerulonephritis, they're going down a long, sad road. It's fixing to get bad for them, okay? Diabetics or patients with lupus, they will keep this chronically. Their kidneys just aren't working. Diabetes is real hard on your eyes, your heart, and your kidneys. It just tears them up because it's constantly having to work to get that sugar out. So people who have chronic glomerulonephritis are usually diabetic. So that might be a question where, let's say your patient's a diabetic, complaining of back pain for several years or some, several months, low grade temp, elevated BUN. You think diabetes and kidneys, those two go together. Okay? Isn't that bad? And it's just caused, like I said, because the glomeruli, the little filters in the kidney, those are glomeruli, are inflamed and irritated and overworked. So that's what the cause of it is, okay? Same with the chronic. They'll have similar symptoms, malaise, headache, shortness of breath, because same thing. They're just fluid everywhere. Can't get it out. Sometimes if you have too much fluid, you might have blurred vision, visual disturbances, hypertension. And same thing, we want to check all those and make sure we're doing their level of consciousness, because when you get all that stuff building up in your bloodstream, it messes with your head. They might also have dry skin too, because all those toxins are building up, so they're itchy all the time. Alright, so did everybody get those? Does that make sense? It's just like it's kind of like Kylo, the kidney infection, but this was caused by strep, and it is kind of a precursor to renal failure.
What is the glomerulin?
That's part of glomerula. It's part of your kidney. It's in the kidney. They're the little filters with the nephrons. They're part of the nephron. So, look in your book and they'll give you the anatomy, but just know that it's part of the kidney that filters, and it's not working. Okay. So y'all feel good about that one? That one's pretty straightforward and easy. You just have to, like I said, know where it's at, and then the same nursing measures that apply for all our kidneys. We'll do that. Okay, now we're going to talk about renal failure, which when you go into renal failure, what's the next step for a patient? Dialysis first, then death. Yeah. So we hope dialysis will help them, but if not, they do die. So I'm going to pass around two handouts from my little picture book. Well, actually three. This one is just one I found for prostate, and it may help or may not, but the other two are for kidney failure. It may help your prostate. So in the first picture, it's just, you can see it says renal insufficiency. Renal insufficiency is what the first stage of renal failure, and then it turns into end stage. I mean, there's just one or two, and then that's it.
I noticed with renal, you can always tell
they look different. They really do. Has anybody had a patient with dialysis yet? Yeah. How did their skin look?
Dry.
Very dry. Were they? What color did their skin look? Remember what their skin color looked like? It is gray. Kind of a dusky gray. And they'll even get sometimes a thing called uremic frost. I've only had one patient that I ever had in 20 years that had uremic frost, and it was cool to see, but sad for him. But their skin literally turns ashy, like white, and they're itching like crazy because all that stuff is coming out of their skin. It looks like a frost. It's called uremic frost.
Do you have map colors for these drawings?
My daughter got me fixed to YouTube. Kind of famous.
Did you see the Chelsea Argentina video?
Yeah, I saw it.
Here's my plug.
Send me everything.
Yes, I'll show you how to do it.
Do
Okay.
you have any colors?
Colors? Like crayons?
Do you have any sheets you give us?
No, that's your therapy for home. It's just what you do when you go home and
We should color them.
And what color would you make her skin? 'Cause she's
Yellow.
yeah, she's gonna be pale and ashy and yellow.
Great.
All right. So with chronic renal failure, they're usually characterized by just they can't remove waste. So they're gonna have a yucky look to them. Poor skin turgor, dry mucous membranes. They're not getting any of that stuff out. Their kidneys aren't working. They're literally failing. And so they'll have headache because of why? Fluid overload. Dry mucous membranes because now they've got all that fluid. Tissue's not getting what it needs to stay hydrated. There's a difference between having fluid overload and the cells having the hydration they need, right? Fluid overload just means it's out in your tissue. Doesn't mean it's necessarily in the cell. So that's why they have the dry mucous membrane. Poor skin turgor and low urinary output for obvious reasons. The kidney isn't working, so they're not making urine. Okay. What's the number one cause for chronic renal failure?
Diabetes.
Yep. Diabetes is tough stuff. If you know anybody that is a diabetic, they're struggling because it's going to get them one way or the other.
So
You have to control it.
is it just diabetes in general or something different?
Non-compliance are definitely going to go into renal failure. But eventually, you know, if they haven't taken care of their body, the kidneys are going to be stressed from diabetes. But the non-compliant ones are definitely one. Those are usually the ones that have already had amputations, they've never taken their meds, they ate whatever they want, they never took their insulin, and now their kidneys are shutting down. So chronic renal failure, number one cause, that sounds like a good question that they would ask you. This patient is a diabetic, and now he has elevated BUN and creatinine. What would you think is going on with him?
One is renal failure.
So that's how they work those questions. Concentrated urine, real thick, dark, it smells strong, they're not putting much out. Diabetes is the number one cause because they've not taken care of themselves. And diabetes, remember I said it attacks all your vital organs, heart, kidneys, eyes. That high sugar just eats all your insides out. So when they're not compliant with their diabetes, they're going to go into renal failure.
A lady explained it to us, like, when you put Drano down your pipes because it's clogged, how it slowly goes in and pushes it and kills
Eats
it.
it away. It literally does. Also, sometimes you'll see chronic renal failure with people who have had a bad burn, like a major burn, and most of their body's burned, or trauma, heart failure, something like that. But the number one cause is diabetes. Okay. Nursing measures.
Increase blood.
Oh, we don't want to.
It says adequate hydration.
Hey, there's a difference though. We don't want to overload them. We want to make sure they're getting
I
what
know, we
they
just
need.
don't give them adequate.
Right. But we don't want to hook them up to an IV because they're already struggling to get the fluid out. So adequate hydration, prevent infections, monitor the vital signs, and teach them the side effects, the things to watch for, because a lot of drugs, if y'all remember from pharmacology, they're broken down by the liver and the what?
We didn't do drugs.
Liver and the kidneys. So if you're already kidney compromised, do we need to give them a bunch of medicines that makes their kidney work harder? No. So we have to teach them that. So hydration, not too much, just enough. Watching for infections. Why do we want to prevent infections? First of all, are diabetics good healers? No, they get sick a lot easier and they don't heal well. But also because our kidneys aren't working, do we want to throw some more strep at them and make it work harder? No. So we're going to prevent infections. That means like telling them not to go out to public places, good hand washing, make sure that people that come to see them aren't sick or coughing, that they don't need a lot of grandkids running around under their feet because they'll cough and get snotty all over them, so that makes them sick. Okay? Talk about their prescriptions. Make sure that they understand they have to take what's ordered, not something different. Because we don't want to work those kidneys more. Strict dyno, just like all our other ones. Weights, because we want to make sure they're staying balanced. We don't want to overload them. And another thing that we haven't really talked about yet, but when you're poisoned, when your kidneys aren't working and your body's poisoning itself, remember we said it starts messing with your head, you get an altered level of consciousness. What's the next step after that? Like it continues to progress and their level of consciousness is deteriorating. What could happen? Seizures. So these little people are the kind that come in that, I've never had a seizure in my life, and I just had one. Well, they're on dialysis, or they're starting the beginnings of kidney failure. So they come in, they said, I've never had a seizure, and I have one. Start looking in there for signs of kidney failure in your question, okay? Because all of that stuff is built up in their system, and now they're severely confused, and then it alters their brain function, and that's why they'll have a seizure, okay? Same symptoms, they'll have that anorexia, edema, fatigue, lethargy, all that. What kind of diet? Lethargy, like fatigue. We don't want to give them a lot of protein because remember their kidneys are already working too hard. Remember how I had to force and push that big oil or protein through the filter? It made me have to work harder, didn't it? It wouldn't just do it on its own. So I do not want to give them a lot of protein. I want low protein. So I have a question. And high carb. Low protein, high carb, because they need their energy.
On renal patients, is there a certain, like you have acute, you have... Oh, okay. And then I'll wait to... Because I was going to ask you, when do they start looking at dialysis, or do they... We're going to get to it when it's in here.
So then the other medicine, what would you think our meds we give them? Diuretics. But we have to be careful because we don't want to mess with their blood pressure too much. So if they get too low or potassium's too low, we're not going to keep giving them. There's also something called a K-Xylate enema. Have y'all ever heard of K-Xylate enema?
Yes.
It makes them boo-boo. But what it is that it's an enema that helps them get some of their potassium. Okay? So it's in your book. I'm not sure what page, but you can read about it.
It should be
1710. Read about the K-Xylate enema in case that comes up as one of your farm questions for doing your ATI. K-Xylate. It's an enema that you can give, and it helps with the potassium on these little folks. Okay? Right up here.
So they always get low in potassium?
No, it just depends. Depends on, because sometimes they will give them a potassium supplement in with their medicines, but again, they're the ones that have to come in every 3 or 4 weeks to the doctor to get blood drawn because it can build up in them because they're not clearing out like a normal healthy body does. So sometimes they're not going to give them potassium because what does potassium do to your heart? Slow you down. So why would we want to give potassium, a heart issue, to a person who's not going to clear it out very well? So that's why they have to be real careful with that. Okay? And renal failure, there's 2 stages. 2 stages of renal failure. You have acute, chronic, acute renal failure, there's 4 stages. They're going to go through an oliguric phase, a diuretic phase, a recovery phase. All this is in your book, okay?
You know what
You said there's 2 stages?
4
There's 4.
phases. Yeah.
Okay, 2 stages, 4 phases.
I'm confusing you, I'm sorry.
Yes.
4 phases of acute renal failure. That is what I said, Angela, and I was wrong, so I'm sorry. 4 phases of acute.
Where's this in the book?
What page is on?
It's
1707, it's in that last section of reading.
1716.
See where it says, do you see it? You have oliguric, diuretic, recovery.
That's 3.
I know there's another one. Onset is the first one.
I don't know. Is the onset in here?
It's just the initial phase. So we phase 1 onset is starting. And then oliguric is where they're having less than 400 milliliters of urine a day.
24 hours.
Y'all need a break? Y'all need to go have an issue?
Yeah.
A conversation?
1710.
Why is it stressing her out? Stressing her out.
So only uric is the second thing?
Our APR thing.
Okay, we'll talk about that in a minute. Let's get through this because we don't have much time. This is the last of
So
the
we're gonna get a break.
If y'all need one,
Yeah, we do.
would everybody need one? Let's take a quick 10-minute break because we still have dialysis to go through.
So we don't need to just know that the initial phase is going to start.
All right, let's go from there.
Yeah, they're on 1710.
Is there any extras?
Miss Robin said they're on 1710.
What is happening with ATI? What is the issue?
She's sending them like extra questions and stuff to answer until then they got it incomplete and that they're not going to be getting their credit for the pre or post time.
Oh, that's one we just took?
For all of the past ones. Like each week. Well, they don't do that. They answer stuff a certain way. Like I was just looking at Shanabi for the last one and I was looking at mine like it was pretty much the same stuff. Like I told you, probably just want to put a lot more on there.
It takes me hours to
Yeah, they
like
said
to
It's helpful.
Well,
That's not it.
she said you need to
Like I
put
did
it
go
on
to my
red.
APR,
And I'm
but
like,
I go to my APR, but I
and I put it on
go
red,
to exactly
like
what
it's
it's
not
I did it, and I put
complete. And
everything
I'm
in.
like,
Well, just like when she always told me to go to job. No, like look at this. I'm going to show you what I did.
Miss Robert. Were you able to
This is for my video test when I did it.
No, I didn't hear the whole time.
Can I leave this on your desk?
So it says, what are the next steps?
I want to get, if we get through, and I think we will, but I want y'all to have this material before we,
It's interesting. It's so
What you doing? That was hilarious. She just walked up and like, that's amazing. What is this? Is that clinical? I was since you do clinical. I do. This team will be here, and we don't have crowds in there. So you don't have your knees for clinical or for well, I know there was a police step. Oh, yeah. They never did find us. I guess not. Like, there's nothing in the
It don't last. If dialysis isn't working, then it's the only other option is a transplant.
Because I didn't know it would do anything good.
If the rest of their body's healthy,
They try. If they have donors. It's hard. And then like usually if they're that severe that they've gone around failure, that the rest of their body's shot too. So that it's almost like they hate to waste a good kidney, you know what I mean? Because it's not gonna survive because their body, the rest of their body's
That's
not.
what I did. She said she was so funny. And I'm like, okay.
Okay.
You don't even ask me if I wanted to go.
Are you okay?
And then it's diuretic.
That's where that great Regine, I'm
Yeah, I didn't see that.
400 meals per 24 hours.
Keep me straight. What page do you?
17
That's the fourth page.
about that though. I don't know how to do it.
I have a friend that had a kidney
And
transplant.
then it's diuretic phase.
And
But that's what it is.
she was gonna start.
These shirts.
She went in to do. They put in the stuff for her to do a home dialysis,
I'm just not good at it. I'll just.
and she got it done and everything, but
And it's one
and she never had to use it. She got a.
Because I don't want to. I don't want to. I will.
And you would think, you know, yay, I got a kidney.
You don't remember that one
She
time
did really
that
hard
I
after she found out that the kidney she got, the girl was 23 years old.
Oh yeah, that's hard.
She took it real hard.
Yeah, it is.
On the third one, it's 1 to 2 days.
Diuretic phase, you're gonna put
Per 24 hours. And it's recovery.
Angela needs to take a picture of this.
So these are the questions that I saw.
Oh,
And it says recovery begins that the glomerular filtration rate rises. Recovery can take up to 1 year.
We don't have any for King either.
This is for the grade.
Yeah, you have to push past mine. That's what she told me. That's what I just did. And it popped up.
What are we doing, King Country?
Well, what grade do we have?
We had a quiz. And she put the wrong grade in there. I know. She said 90. Yeah, and I'm gonna go top 100. I'm gonna need to. You need to put 100 in there.
Together.
I'm serious.
Okay,
It was
what about
100
that
on the
quiz,
quiz.
Miss,
And she put 90 in there.
That probably know it being. She said just throw it all out.
But that was 100. I didn't do that.
Oh, yeah, 'cause she haven't got a question right.
Yeah, no, but the first quiz that we had.
I thought the first quiz we had was with Miss Listening.
We did, but she
Every time
apparently
you
she
say
said
that,
she can't find it.
I feel like you're saying Miss Listening, and it's really bad.
Oh my God, yes.
No, she was done. When I went to go get my phone, she was like,
Remember we were watching the House of Cards, and like at one point everybody was laughing. So she was like, real quick, I just want to know, why are you guys laughing? This is not funny. No, she said it. Yes, she was. She paused it. No, she paused it. Yeah, she paused it.
She paused it because it was, no, she paused it because people ended up leaving.
Yeah.
So it was after the time was up.
Okay, so she had got hot because we was leaving because it was 5 o'clock. She was like,
afternoon.
"Oh, make y'all stay." We were still like, "No, was it funny?"
Oh,
We're like, "I don't understand why this is funny." And I told you, I did. This is real life.
She tried before she left.
I don't get this job. I'm sorry. I just want to know what was funny. I don't care. I didn't find it. If I saw somebody go, "Sally, we're leaving," in real life, I would still laugh. Like if that was still a real life
Yeah,
situation.
she paused the movie and got mad.
Oh, she was angry. She was like, "This is in real life." I loved it.
Well, we started laughing more when that little boy punched the shit out of the guy.
Oh, and she got mad at me because I was like, I'm proud of that kid for taking up for his mom. And she was like, why would you promote violence like that?
Dude, that was so. I miss her. I know. I miss her voice, dude. She's funny.
This guy was unimpressed with the woman on the movie, so the little kid came up and he punched the dude and was like, leave my mom alone, you know?
So you guys, we
And
didn't
I was
get
like,
that.
yeah, I'll be proud of myself.
It'll only be half the test. We were concerned about our great. Listen, it always starts out real bad. You know, it'll pick up. Everybody fail all your tests, but don't you worry. My other students have the same concern. It'll be okay. The one time you said this, okay, what I'm hearing is, okay, Andrew, you don't like the way Miss Wilson teaches. Okay, Angela, so what you're saying is basically you don't like it.
usually
Oh, she said I wear my headphones.
or something.
And then she said everybody was like, and then she's like, no.
It's a report.
Yeah, she was like,
And some like positive reviews. So the goal is to get at least 10 questions and 10 brands. I already counted those.
Okay, so 10. And they go to google.com.
Basically, what they do is go to google.com, click on maps. I like the notepad.
I've been doing something for it.
Maps, and then once you do maps, you enter a list of all the public apps. And then you go to a tab that says write a review.
What's the address? Oh, wait, I'm making it.
Yeah, 4620. Oh. Do we have the thing today? Do we have something?
Yes, level 1.
Where is it?
It's going to be in that break room that's over by Allison's office, that back break room, stand break room.
Okay.
They're going to do their presentations, and so we'll be around 1-ish. So you can come back to that same room, and if you want, you can watch their presentations, because they're real creative. And then we're going to go eat.
Okay. Is it for nursing only?
Well, you can come. I mean, it's just that it's their nursing class, but you're welcome. I invited you and Allison and the other instructors. Because I want them to show off their projects, how well they do.
Okay, when do the presentations
The
end?
class starts at 12:30, and I don't think it'll take long, so.
Okay, so
You
if
can
I
watch the
can...
presentation, and then you go eat if you want to, or just call it 1.
One?
College address,
Uh-huh.
and then what?
And then when the... Fill this out, the list of college addresses, it'll automatically bring them to a page that will say write a review.
This was the truth. I refuse to believe that she doesn't think
Bring
that.
them to that, and then
It's funny. That's just,
they can just... The goal is to get 5-star. Thank you.
And then I'll get. You have to be level 1, because they might do better reviews. These are kind of
Any
cheap.
level. I know this is the best one.
girl, she calls that whole baby. She shut it down.
All right, thank you.
Thank you.
Appreciate it.
She just want to know real quick.
Okay, I have a special request for anybody who wants to be nice and feel like you want to be nice today. I know you're a little stressed. This the college is needing you to go to google.com and fill out a positive review. So if you're feeling generous, you can write a
Would a
positive.
business office stop calling me if I do it?
So if you want to do that, if you want to write a positive review, you can write if you don't think a positive in your when I'm done with whatever my lecture sounds like. It's what you put into it. Yeah.
Okay, let me see if I can make it. Because I'm gonna go WPA if I didn't survive. However, I did ask for those things around.
Alright, let's get started so we get done. Okay, I want y'all to get this because the dialysis is really hard to wrap your mind around. And y'all will probably see a lot of that because you're going to be working with a lot of elderlies, or unfortunately, dialysis has become more of a necessity. Alright, so in acute renal failure, chronic we already talked about, and then they go into acute renal failure, which means like it's happening fast. So there's 4 phases. It's on page 1710 in your book. Have the onset, which means okay, they've gone from chronic, they were percolating right along, and now the kidneys are shutting down fast. So that's the onset phase. And then you go into oliguric. Remember that was on our test, I think, wasn't it? Decreased urinary output, because now the kidneys are shutting down, so you're not going to be making enough urine. Decreased urinary output, and your BUN and creatinine are going to be high because again, your kidneys aren't working, so they're not clearing that BUN and creatinine out of the blood. Alright? They're only making less than 400 milliliters in 24 hours. What's our normal, very, very basic, for 30 an hour? 30 an hour times 24 would be what? Somebody do the math. I can't even do the math today. 24 times 30. 720.
That would be normal.
720 is what the very minimum, because the doctor says if they're 30 cc's an hour or milliliters an hour of urine, then you're okay. So at the very minimum, you should be making over 700. When you go into this acute renal failure, you're making less than 400. So you're not making a lot of pee. Your kidneys are not working. Then you go into the diuretic phase. You come in and you're all swollen and puffy, and because you're not making any urine, that fluid, you don't have anything to hold it, and it's going out into your tissue. So your blood pressure's going up, your head's hurting, and they start diuresing you. They give you diuretics. Well, what does a diuretic do? It makes you pee. So your urinary output is going to go up. They're going to have 1 to 2 liters. That's 2 bags of fluid, IV fluid. So they went from less than a small bag of IV fluid to 2 large IV fluid bags in a 24-hour period of urine. So the kidneys went from not working at all to now we're putting them in overdrive. We're diuresing them, okay? And then you go into the recovery phase where it could be up to a year, where the kidneys, they're trying to get them back to normal, they're trying to get them functioning, they're tinkering with their meds, trying to get things working, okay? This is why you're in chronic renal failure. You'll kind of flip back and forth between that. When they percolate and do okay and function, but not much if you're in chronic. And then all of a sudden, you'll go back into kind of like a phases, like a crisis, like with sickle cell. You can percolate right along, and all of a sudden something hits you, and you go back into acute. Okay, so it's the same thing. Then they get them loaded back up, fixed up, and then they'll percolate along for a while back in chronic.
So it's just nonstop.
Yeah, it's a bad cycle. Okay, so everybody got that? You got the handouts for your chronic renal failure. All right. Then, when this is not working and you've done this back and forth, you've yo-yoed back and forth, you go into end-stage renal disease. All right, that's where 80% of your nephrons are severely impaired. It's bad. There's hardly anything left of your kidney. Okay. The causes could be pyelonephritis, like chronic kidney infections, chronic glomerular nephritis. It's just damaged the kidney. All that infection has just damaged your kidneys to the point where they will not work anymore. You're in renal failure, end-stage renal disease.
End stage?
End, like E-N-D.
Is there a time frame on that? Like,
Just depends on the body. Everybody's body is stronger, or weaker. Depends on how well they take care of themselves and what other comorbidities they have. So this is where, you're just, everything's shut down. All those other urinary things we were talking about, like kidney stones, infections, diabetes, everything has accumulated, and now the kidneys are not working. You're going to go into end-stage renal disease. And this is where you go on what? Dialysis. Yep. I've got you some pictures. I know y'all are excited. More pictures, yay. So, if you've had a patient already at clinical that's on dialysis, you may have noticed they have a shunt on their arm. Anybody have one yet? Did you get to feel it? In here. Got to feel it and hear it? Felt the thrill?
Remember, my little man had one, but we didn't.
I know, we didn't get to see him. He left. He went to dialysis that day. So, when you're in dialysis, you are not a healthy person, okay? This is like the worst example of all the stuff that we've been talking about with cities. This is like the culmination of all of it. You're sick all the time, okay? You've got nausea. These are the signs and symptoms. Nausea, maybe some vomiting. Because why? Why are we nauseated? Retaining fluid. We're retaining all that bad stuff, the toxins that we don't need. Okay? Lethargy, same reason. We don't have any energy, nothing's getting out of us, we're being poisoned. Decreased strength, anorexia, itching.
Is that signs and symptoms?
Yeah, signs and symptoms. I abbreviate a lot.
why isn't the internet? Where you see the internet?
It's pruritus. Pruritus means
Oh, I
itching.
didn't get my nursing term together.
Pruritus is itching.
Where is the itching?
Just say it. Itch. Okay. This is where they're going to have a decreased output, muscle cramps, and this is where they have that uremic frost. Okay? Has anybody seen that uremic frost on a patient yet? They literally look like they've been, in the movies, how they show somebody that's been in a freezer for 2 or 3 days and their skin's like white and everything. That's what their skin looks like. This was a little African American man that I had in end-stage renal disease, and he literally was just white. It was sad. And he had been
Can you see that on my kids?
Yeah, because it turns into a dusky color. We get real pale, real ashy. We can get ashy too. Not like black people.
She said we can get ashy too. Don't touch me.
I can't get ashy. I've seen them get ashy.
Yes.
but I never get there.
Dusky. You might see the term dusky skin on your test. Dusky. That's what they describe it as. Okay. Are they going to be very alert? No. Are they going to be oriented? No. So decreased level of consciousness, maybe some disorientation, maybe a lot of disorientation. But remember, these are people that by the time they've gotten to this stage, they have other issues that they're not taking care of their body. So they're going to be sick in other ways too. So they're going to be disoriented from multiple things, probably. But definitely when you're in end-stage renal disease, because you're not getting rid of the toxins and they build up in your system and make you disoriented. Would my BUN and creatinine be up or down? Yep. And that's called what? We said it yesterday. At a term, when your BUN and creatinine are high. Azotemia. That's what that means. Your BUN and creatinine.
Some medicine or something called azo that you can take.
Azo standard. Yeah. It's not the same thing though. That's like generic BUN. I have it.
Is this the stuff that you need to check?
That's the elevation.
That's BUN and creatinine. That's what it's called. Like the term. High blood pressure from all the fluid, right? Okay. And then Kussmaul's respirations. Has anybody ever heard of Kussmaul? Y'all ever seen that on your test or anything on your ATI? Okay, this can happen with your diabetics that are going into metabolic acidosis too, or respiratory acidosis or alkalosis. Kussmaul's respirations are just a real deep, fast breathing. Okay? So they'll come in and they're, usually if they're in Kussmaul's, they're going unconscious, but their sugar's so high, they're going into a sugar coma. But with this, the reason why they're going into it is because their kidneys are shutting down and everything's elevated. So they'll have that almost like a racehorse that just finished a race. Real hard, fast breathing. That's what Kussmaul's is. So you'll see that in end-stage renal disease as well. And then they go, if they're doing that, they're going in usually unconscious and into a coma. Okay. What are our nursing measures? Same ones we've been doing. I know, weights, checking level of consciousness, vital signs. What about skincare? Is that important on this one?
Yes.
For sure, because now they're real bad off. Skincare. It's not the highest priority, but we definitely want to address it. Make sure that they're getting vitamins and protein, okay?
Wait. So you want protein, why?
Because, well, some protein. Because they're not eating and they're wasting away. Because we're fixing to put them on dialysis. These
They're
people
just
are
not
going
getting
on
rid of
dialysis.
other stuff. Now it's no region.
Because you're going to put them on dialysis and it will do it for it. Remember, it takes the blood out, clears it, and then puts it back in. Alright. So y'all good with that one? Okay. 8 to 10 grams. It's not a lot of protein, but they need it for their skin. Put it on there. 8 to 10 grams. Okay. Now they're going to go into dialysis. So you can have, there's 3 kinds of dialysis. Your syllabus has peritoneal dialysis, hemodialysis. Everybody got this off the board? So these are the people, like they're in end stage. They've come in Kussmaul's respirations, and the doctors check their BUN and creatinine, and they're off the charts. He's like, okay, it's time to go ahead and put them in dialysis. If they already have their shunt, they go on in and do dialysis for them. If not, they got to get a shunt. They get them stabilized, get a shunt, and then they're going to be starting dialysis. can do dialysis from home, kind of with the chronic ones that have had a shunt for a while when they've done it. Other ones, it just depends on their health. They don't tolerate it, so they have to stay and do it in a clinic or in a controlled setting. All right, so dialysis. This is the last stuff, y'all. Hang in there. We're almost done. It's where we take all the blood, pull it out of our patient's body. The machine circulates it, cleans it, and then we put it back in our patient's body. Okay. There's some pictures on page 17, 16, and 17, 15, so you can see the kind of way it works. If you've got hemodialysis, that's where, what does hemo mean? Yeah. We're clearing the blood. That's what the machine, the blood circulates it, and it shows you a picture there. They can even graft the artery and the vein so that it circulates from that one little thing on your non-dominant arm, the shunt. Hemo is used with the patients that are real acute, and it's just irreversible renal damage. They've had fluid electrolyte imbalances. They're just bad off. The machine circulates their blood, cleans it, puts it back in the body through their shunt, and that's on page 17, 15, okay? You can see where they made a fistula between the artery and the vein. Fistula is just a hole. It can be anywhere in your body. And they've put those two together. That way you only have one insertion site. You don't have to have one where they take all the blood out and one where they put all the blood in. It's in one spot, okay? They're going to need their nursing measures for people who are like this. Obviously, we're tinkering with their volume, so what vital sign do we definitely want to watch?
Blood pressure.
Blood pressure. If I don't have a lot of fluid in my body, my blood pressure is going to drop. So they're going to be monitored. This is those little dialysis clinic patients that sit all day long in the recliners, and they're hooked up, and somebody's checking their blood pressure all day. We make sure that their access site is kept clean and patent. Access site would be their shunt on their arm. It's always a non-dominant arm if they can get it in there.
And you don't do anything with your arm.
Don't do anything, exactly. You don't put a blood pressure cuff on that shunt arm, because what are we going to do? Yes, ma'am. Yeah, we don't want to include that. That's just like an IV site for these people. Instead of putting IV fluid, we're putting blood in. So do we want to clamp it off with a blood pressure cuff? No. And it can clot it off, and then they don't have a way to clear their blood, and then they're going to die. All because you put it on the wrong arm. Wouldn't you feel bad? Okay. So make sure their access site is secure, patent, free of any kind of infection. Patent means open, right? We don't want it to clot. And no infection there. Watching it, make sure my signs and symptoms of infection on the skin are redness, streaking, swelling, pain, all that. Okay? And give them a lot of support. They're going to be with you all day. So if you're one of those that like to talk and you're real lovey, you might be a dialysis patient. I ain't got time for that. I love my patients, but I'm in and out. I'm not that personality. I'm real hyper.
So never work with pregnant women.
So no, I didn't like to be. I'm just hyper, and I can't sit in one spot all day with the same patient. So, but if you like that, these are the kind of patients you would enjoy being with, because you're going to be with them all day, and you really do become their support system because you're with them every day, every 2 or 3 days. So, if you like long-term care and that kind of thing, this might be your thing. And they make good money. Dialysis nurses make real good money.
Yeah, they do.
And they can travel and go to different outer regions and make even more money. Just saying. Alright, so just know those, because that's a good select all apply. I want to make sure my site's clear, no blood pressure in the affected arm, in the shunt arm. You gotta be careful how you say that. I've had a lot of trouble with vocabulary.
Do you have to be an RN to do that, or?
They have an RN that supervises, but I have a friend that's not a nurse at all, and she runs a dialysis clinic here in Lubbock because she was trained on the job. They have an RN that supervises, and then the LVNs will usually go around and hook them up, start the machines and monitor them the whole time. And they make really good money because it's 100% reimbursement from Medicare, because you can't live without it.
Let's get a dialysis.
And it's usually a daytime job. It's they're done 8 to 5, so if you got young kids, I think
And they usually go with You know how dialysis patients, they do the Monday, Wednesday, Fridays, Mondays run like that too.
Yeah, they do. They have good hours. Alright, so, does everybody understand that first before we get to the last one? Because peritoneal dialysis is where we're going to come in with our little science experiment. Does everybody understand? If you have hemodialysis, that's the blood circulating through the machine. Okay? Peritoneal dialysis. What does peritoneal mean? Peritoneal area is that space between like your ab muscles and your organs. Like the thoracic, you have that space between your lungs, the pleural cavity. Peritoneal is in the abdomen. It's that kind of gap. So peritoneal dialysis is where they're going to use that area to dialyze you. Okay? They don't, it's done like 4 times every day, 7 days a week. Don't go with peritoneal dialysis to the clinic and sit all day and then go home and then come back every 2 or 3 days. This one you do it all day, every day. You don't have to go to a clinic. You're doing it from home usually, or a home health nurse will come and help you. Okay?
It's like 30 minutes every day.
They do it, yeah, it takes 30 to 40 minutes, depends on the patient. Okay? There's no machine involved with this one. There's no machine. Let me tell you what it is. Let me get it out, okay? This is where you use osmosis and diffusion, all right? What we were talking about earlier. You're going from a high concentration in the blood to a low concentration. That's how you're going to get all that stuff out of your body. There's a picture of it on page 1716. You see the bag? So they insert that catheter into the peritoneal area, that gap in between the organs and the muscles. They infuse that fluid, and it's going to go in and pull all of that stuff, like we did with the sugar cube and everything. It takes all that high concentration, pulls it out of the cells and out of your bloodstream and your tissue, and sits it right there in that peritoneal cavity. And then, after you wait a few minutes, you tip the bag down, the catheter down, and it all pulls out and drains back out. All the toxins and the fluid come out together. Does that make sense? They can keep standing. We got a few more minutes. Who's it?
Somebody showing
Is he good looking or not?
No.
He ain't good looking, ain't getting it. Okay, so with peritoneal dialysis, that's what you're using, is just pretty much gravity and science. There's no machine involved. Some people can tolerate this better because they're healthier, or they're not as severe, or they don't have insurance and this is a cheaper route, things like that. Sometimes, it's just done because it's a choice. But osmosis and diffusion are used where it uses that peritoneal area and it crosses over that membrane, just like it did with the coffee filter. The only reason you couldn't do this is if you've had like pelvic surgery, abdominal surgery, inflammatory disease or back pain, because that's going to have scarring there. You're going to have a lot of scarring that will interfere with that drainage system.
You get back pain?
Yeah, because a lot of them will say during this, if they're retaining all that fluid that's not coming out, they'll have back pain as a major symptom. So if you already have chronic back pain, you wouldn't know. And then you're retaining all that fluid with the toxins. So you wouldn't do this for abdominal surgery, back pain, right? Or inflammatory disease, because they're not going to be able to get it all out. So it just depends, like I said, the patient, but this used to be very common. It's not as much anymore because they get 100% reimbursement from dialysis, hemodialysis. But just know that's what it is. There's 2 kinds, okay? Because you may actually have a patient that has to do this, and this can be done at home. If you're a home health nurse, you have to help them. You have to teach them how to do it. Or if you're in the hospital for a long-term care setting, you may have a patient that has this. So know that's what it is. They just put that catheter in the abdominal cavity, the fluid goes in, and then it pulls it all out with the other fluid. Okay? They have a little stoma. So if you look on page 1719, there's a picture of a stoma. When we went to Brownfield for clinicals last time, that was the only stoma urostomy I'd ever seen. In 20 years, I'd never seen. I'd always seen a colonoscopy, where the colon empties into a bag, but I'd never seen a urostomy. It was where the urine was emptying.
And it shows you in that picture on page 1719, they literally take part of their colon, which is just a long tube of poop, and they cut it apart and use it like a segment of it to replace the bladder. So they'll take the bladder out if it's sick or injured or whatever, and they use that piece of tubing from the colon, and it comes out, and they have that little bag of urine, of urostomy, coming straight out of their belly. So
So do it look like a stone?
it is. It has that little round poop. But instead of poo coming out,
It don't
it's urine.
stink like that other one.
Well, they smell like urine. Yeah. There's no poo because it's just a tube. They clean the colon. They're just using it your own tissue because then you won't reject it, right? Because it's your own body. But that's a picture on 1719, just in case you ever see a urostomy. That's a real interesting thing. You don't see very much anymore. So we talked about our nursing interventions are for any kind of dialysis patient is hypotension risk because we're tinkering with their fluid. We got to watch that blood pressure. Would you think we need to watch for peritonitis infection in that area? Because if we're putting a catheter in and out 6 and 7 times a day, you're risking infection.
I have a question. Okay, so you know like when they got a stoma, if they want to do it, they just take the bag out. Do you do that with that other one? Or
With the urine?
don't do it?
Well, this is for stomach are usually for bladder cancer. If they're doing the dialysis, you don't need a stomach. It's not going to work. They're putting a stomach, a smaller stomach. It's not the same one.
I'm saying like, you know how, okay,
No, go ahead and say it. I think there's
no, okay, because when they got just a regular one with the poop, they want to hunch, they take it off. This is really soft. Okay, so
you mean
like,
so they can just empty into the toilet with their urine bladder?
No,
she's talking about
when that's sex.
Oh.
listen, we learned about
I
this
mean, I
last
guess you
one.
could.
But I'm saying like, would that one just leak peas?
No, because it's got a bag on it, just like the other one. They leave a bag on it.
Hey, so let's take the bag off, right?
Well, if it pops, I mean, you'd be covered in pee. So I would leave my bag on it. Fine anyway.
I would leave my bag on. Because I'm wondering, like, do it just leak and then you have to, like, push, like, do you still have an urge?
This is
This
my
area is hurting. Can we keep it?
So just remember, with dialysis, your main thing is to watch their blood pressure, okay, and watch for infection and pain and hemorrhage. Did you have anything else you wanted to say about it, Waldo? What were you going to ask me? Okay. Dialysis is real simple. You're either on the machine or you're doing it with the abdomen. You need to make sure you're watching for changes in their blood pressure, level of consciousness, and infection, okay? Any questions on anything we covered today? Because that's all new.
Question, you ain't gonna tell us how we can access you on YouTube?
Go to, hold on, my daughter had to write the directions down for me. Hold on. Angela, I sent it to Angela last night. Go to YouTube and you can type in level 4 lecture 4 nursing and see what pops up. Level 4 lecture 4. I just put about week 4.
You should have made it something unique. All you had to do was.
But y'all talk about me.
It's a bunch of other stuff coming up. What else is in there?
I got it.
It's right in your name.
Release the joy. Oh, there you go. This is yours.
What's that? That's mine.
It's not the same. That's perfect. I don't remember it. You did it, I didn't take enough time. 38 minutes. That's not enough time.
Is that on YouTube?
today's on there, okay? Shania, no, not Shania. Who was asking me about? Was it Chelsea? Were you asking?
At least you be dressed cute, girl.
Don't laugh and make fun of my mom arms and my accent. Strictly for learning from mom arms. I should have kept my sweater on yesterday after I watched it. I was like, oh, ain't nothing wrong with your arm.
That mean I got
I got the back flaps.
If they say something, tell them. At least it was my cord.
Hey, I'm 44. I said, just take what you get. Okay, we were talking about, this is just extra, and we'll do it later when y'all have, we only have 4 more weeks of lectures. Did y'all know that?
Yes.
And then the next 4 weeks after that, y'all will be doing ATI.
You said the next quiz is open book? Just gonna make sure I get
Yes, the next time we see each other, Thursday, y'all have the open book quiz.
y'all.
And so those last 4 weeks, I'm not really sure, how did y'all do that? Did y'all have class time and review, or did you stay in the ATI lab?
You do loud review, it's gonna be straight. Let me look. I can definitely tell you.
So anyway, in the meantime, while she's looking that up, if you have questions about something like we were talking about blood gases and stuff,
The last exam was on week 9, and then they no more.
and then so what did y'all do after that? Did y'all
Week
say
10, you're gonna do your ATI predictor, and then you're gonna do like your focus for your finals. And then week 11 is when that live ATI.
so it's all the focus and everything is in the lab?
That's stupid that they even do live review week
If
11.
you need extra help or something's not clear by then, let me know, because I have a lot of resources. So we were talking about pH. How do you remember pH? 7's in neutral. And then, like, we were trying to remember yesterday, I was like, I don't know how you can remember which way is which. So it's down to 0, so I mean.
They're using blood pH.
So, yeah, if it's less, acid only has 4 letters in it. So it's shorter. Alkaline, so this is like the number's bigger and it has more in it. So you can remember it that way. Does that make sense? So acid is a shorter word, so the smaller number. It only has 4 in it. So it's 4 letters, it's acid. If it's alkaline, it's a longer word, more numbers. It's alkaline. Okay. CO2 is always an acid. It's always. And then bicarb, I forgot what your bicarb is your alkaline. So when we talk about that later, you do your metabolic acidosis and alkalosis, and then your respiratory acidosis and alkalosis. We'll go over that. But if you can remember, all you got to remember about it is CO2 is always your acid. If it's high, like your CO2 is high, you're going to be in acidosis. It's the acid. The more CO2 you have, the more acid you have. Either respiratory or
like 6 is acid. Right?
what if you're
Well,
CO2?
you got 1, 2, 3, 4, 5. Like, the 7 is the middle mark, right?
Yeah, 7.
Okay, so what are these numbers for? 1, 2, 3. If it's 7 point any of those is acid?
7 or less is acid.
7.35 to 7.45.
7.1 or more is alkaline. But just know that CO2 is always, it's an acid. So if it's high, we'll talk about it later. CO2 is an acid. And so if your CO2 is high, you're going to be in acidosis, your metabolic or respiratory. Okay? So the more CO2 you have, the more acid you have. So you're in acidosis. Bicarb is your base. So if it's higher, you're going to be in alkalosis. But we'll go over that more. Shania had, yes, your sweet classmate Shania has a little cheat sheet from that from last year, so I'm going to pass those around too. Acidosis and alkalosis is so confusing, but when we'll get to it, and I'll try to make it simple, because it is, you have to stop and think. It's almost like mirror image of what you think it should be.